Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome back to yet another fellowship snippet. Before we dive into today's snippet, there's so many good news and so many things to celebrate. So, first of all, congratulations, Maddie, for getting a permanent staff specialist position at North Shore Hospital. So, congratulations.
Thank you. Big relief. Nice to have some security, and it's a great place to work. So,
And I think you worked really hard over the last many years since I know you. So, well deserved. Also, this week we had fellowship exam and results came out, and some of our colleagues, people that we know, and then they follow our fellowship prepcast very closely. Leon and Bianca, they both passed. They have said massive thanks to fellowship prepcast. But also, we received a very nice email from Tom for his success in primary prepcast. So a lot of people are accessing the fellowship and primary prepcast, and we are glad that it's helping in their journey to get to the next stage. So we are really grateful for your feedback and keep sending us your positive feedback on the way we can probably get better. So it really helps us to do these things for you. Thank you.
Yeah, definitely. It's really nice to hear that people are listening and getting something out of it, and also that people are getting through their exams, which is a massive hurdle. So congratulations. And for those fellowship people, no more exams. Amazing.
That's right. That's right. And I guess one of the things that it resonated with me is even if you struggle for the first or second time with the fellowship or even primary exam, don't give up. I think it's usually the problem with the technique because we all have reached the stage where we all are very good doctors, very good human beings, and we are intelligent. That's why we are here in this job. But it almost sometimes is just a technique problem. So if you just keep working on technique and find the right mentorship, you will definitely get through these exams. These exams are not big demons, so they're just an exam. It's not really difficult to get through. If you want any advice, reach out to Maddie or myself. We will be very happy to help you outside this podcast as well. So, Maddie, let's dive into today's first snippet. So, you are the duty intensivist at a large neurosurgical center, and you have received a call from a general practitioner in a small rural emergency department. The GP reports that she had a 40-year-old male who has been assaulted and beaten by a crowd outside the pub, and he was found unconscious at the scene. Upon his arrival at the hospital, the GP has intubated the patient for a low GCS. On examination, the patient has obvious facial and head injury with a blood pressure of 180 over 100 millimeters of mercury. No other injuries are immediately apparent on clinical examination. However, there is no facility to perform a CT scan. After speaking to your neurosurgical registrar, who has accepted the care of the patient, the GP is now seeking an urgent patient transfer to your intensive care unit. So, what are the kind of questions that you would ask to this GP in rural remote emergency department over the phone so that will help you to make some assessment of this patient?
So I would have an EMST or an ATLS approach in this traumatic patient situation. So I'd want to know about the patient's background, the events surrounding the assault, and information regarding the primary and secondary survey. So in terms of the background, this would involve the details of the assault. So you often hear about the MIST acronym that's used. So this involves the M for mechanism. So that's including the timeline and the estimated duration of unconsciousness. And I for obvious injuries, S for any signs and symptoms, so what their vital signs are. And we know that there's no obvious other injuries, but just a bit of an overview of the initial parameters. And then T for the treatment given so far and what is currently running. So this might involve things like, are they on any sedation? Have they been paralyzed? Have they had things like antibiotics or an ADT? Any fluids, any treatment for this blood pressure of 180 of 100 over 100, so any antihypertensives. And then regarding the patient themselves, the GP might not know, but if it's a small town, maybe she is familiar with the patient. So you might think about something called the AMPLE history. So this is A for allergies and for medications. And specifically important in this likely traumatic brain injury situation is anticoagulants or antiplatelet agent. P for any past medical history. L for when they last ate, which is tricky, but we know that they were at the pub, so there might be a bit of an idea about exactly when they had their last drink or food at the pub. And E is covered already in the MIS thing, but any events surrounding the injury. And then I'd like information about the primary or secondary survey. So primary In terms of the airway, we know that he's now intubated, but what the grade was, if there was any difficulties, what size of ET is in situ, if they've been maintaining C-spine precautions, or if there's any suspicion of injury. And if we know that he's got obvious facial injuries, but were there any trauma to the airway from the assault. From a breathing perspective, the patient's SATs, the ventilation settings, and if there's any issues with compliance or oxygenation, their entitled CO2. If there is facilities, have they had a chest X-ray or an ABG to confirm the adequacy of their oxygenation and ventilation? And from a circulatory point of view, the hemodynamic status, so this blood pressure of 180 of 100, have they been persistently hypertensive, or is that in the context of things like waking up after intubation? If any medications, like I said, have been given for the blood pressure, what IV access is present, if there's an arterial line is in situ, and if there's any other blood tests or they have the facility to do other blood tests, especially things like a hemoglobin or coagulation status. And from a disability point of view, the GCS prior to intubation. So we know that he was intubated for a low level of consciousness, but what does that actually mean? What was the breakdown? If there's any lateralizing signs or pupillary abnormalities, any seizure activity, and again, the current sedation running and the current GCS if he's not still paralyzed post-intubation. And from an exposure point of view, the temperature and any description of the external facial and head injuries that can be seen. From the secondary survey perspective, if there's had a log roll, and if there's any other injuries, and then logistically, what the neurosurgical plan on arrival is. I mean, he'll likely need an immediate CT. The weight of the patient, just to get prepared in terms of logistics and drugs, if retrieval has been contacted, and if there's a next of kin and the social supports.
Thanks, Mary. And there is a New South Wales ambulance document which is endorsed by the ACI around the pre-hospital management of major trauma, which is a useful document to go through regarding the details of each mechanism and injury and severity and transport stuff. Also, it provides for New South Wales destination, which are the trauma centers and where that GP can particularly refer this patient to. So similarly, each state will have destination trauma centers that particular patient can be transported to. So having that knowledge is also useful because certain times in certain states, even if it's a major trauma, there are certain aspects of the trauma are dealt differently. For example, if this patient had trauma and burns, then obviously that the destination will change. So having that comprehensive history is useful because then once you accept the patient and then you find out that, oh, this patient also had these other issues which can't be dealt with, even if we are a tertiary center and can't be dealt in our hospital, then you need to re-refer again to the next center. So getting the comprehensive history and finding out all the details is really important. One more important thing about the logistic that you mentioned, because sometimes, as you said, one is the obviously the retrieval contacted, but also we need to find out what's distance between this hospital and a tertiary, our hospital, because then that will impact your estimated time of arrival, and that also might impact your bed situation down the line. Because if this patient is going to arrive in 8 hours' time, how the ICU bed situation will look like at that point in time. Most of the hospitals will have no refusal policy for trauma, so you have to accept the trauma. Being mindful of what's your acuity in ICU looks like in next 10 to 12 hours by the time this patient arrives is also important. And also notifying your other services within your hospital, because every service will have follow-on effect of this accepting this admission. For example, the blood bank, your status, and obviously your trauma services and all those things. So informing all your colleagues, making sure that everybody's aware of this patient coming to ICU and might have to go through ED or even to theater first and then come to ICU. So once you formally accept the patient, then you need to sort out these logistical challenges. Now, you ask those questions, GP reports to you that patient GCS prior to intubation was 3 and his left pupil is currently fixed and dilated. What advice would you provide over the phone to this GP?
So I emphasize that this is an emergency and the patient is demonstrating signs of raised intracranial pressure requiring urgent management, ongoing neuroprotective measures to reduce secondary injury, and expedited transfer to a neurosurgical centre. So in terms of the raised ICP management, I'd advise a tiered approach. And also this would also depend on what was available in their centre. So firstly, ensuring that standard measures are in place so that the patient's head of the bed is raised to 30 to 45 degrees at least, or that and all can tilt the whole bed if there's spinal precautions. If there is a cervical collar present, then to take it off and use sandbags instead. Make sure that the ETT is taped rather than circumferential ties, and ensure that the head is in neutral position, and then avoid any unnecessary PEEP in order to reduce the ICP. Then tier 1 therapy, which would initially involve osmotherapy. So it would depend on what is available. So either 3% hypertonic, 3 mils per kilo, or mannitol, 0.25 to 1 grams a kilo, ensuring that the patient's adequately sedated and has adequate analgesia. So this would also depend on what was available and what sedation is running. So I'd advise to bolus the same. So propofol bolus 0.2 milligrams a kilo, or midaz 0.1 milligram per kilo, or fentanyl 0.2 micrograms a kilo boluses, and increase the infusions, and ventilate to a PaCO2 of about lower end of normal, so 35 to 38 millimeters of mercury. If the pupil's still dilated and fixed, and move on to tier 2 approach, so paralyzed with rocuronium 1 to 2 milligrams a kilo boluses, and then aim for mild hypocapnia, so PaCO2 of 32 to 35. And tier 3 is if the pupil's still fixed and dilated, if it's available, having a thiopentone. Generally, I'd start with 100 milligram boluses, ensuring other neuroprotective measures are still in place. So aiming normoxia with SATs of greater than 92%, normotension. So it's always difficult to advise like what blood pressure to target in terms of the ICP we know is raised, but we don't know what it actually is and what the CPP is. But the major thing is to avoid hypotension. So generally aim for systolic blood pressure of 100 or more, BSL of 6 to 10, and normothermia. And then this patient needs urgent transfer to a neurosurgical centre. So depending on, I guess, what the closest one available is and how quickly we can get them there.
That's correct. So this is a bit tricky situation to deal with in the peripheral hospitals, depending upon the capability that they got, and also the time that retrieval will take to get there and transfer this patient safely to tertiary trauma center. Now, another procedure that can be considered, depending upon the expertise and the equipment available in the periphery, is the emergency burr hole. And it has been performed in regional hospitals in the past with a good effect. And obviously you would like to perform that on the side of the fixed dilated pupil because the path of the third cranial nerve. So it's important to keep that in the back of the mind and ask that question whether there is any general surgeon available who can potentially liaise with neurosurgeon who can then guide, or if there is equipment available or somebody who has done it before there in that hospital, and then that can be one of the potential consideration. Again, it's going to be very hard, and also some of the medications that you mentioned, finding those medications in the regional remote center might be a challenge. So principle is do best you can with the best possible intent, and that's the kind of advice that you will give to the most of the GPs in this kind of situation.
Yeah, but you're right. We should also liaise with neurosurgical colleagues at our centre because the whole is definitely an option, especially if there's none of the other tier therapy that's available has any effect.
Yeah, and that's why sometimes having a conference call with everybody in there, and even nowadays with advanced technology, even doing like some sort of video call will be quite useful so that you can actually see the ground reality and then kind of guide people. You mentioned tier 1, tier 2, and tier 3, and some of the drugs that we use to reduce the intracranial hypertension is mannitol and hypertonic saline as a part of osmotherapy. So can you please outline advantages and disadvantages of each of them?
Sure. So the advantages in terms of mannitol is it's thought to decrease the blood viscosity. So that might physiologically then improve intracranial blood flow. It's been around for longer and used for longer. So it's more studied. It's cheaper. It's got a rapid effect and it acts as a transient volume expander, but quite transient. And it can be given peripherally. In terms of the advantages of hypertonic saline, it is also cheap, but it doesn't cause the same massive diuresis and hypovolemia that mannitol does. It's stable in storage and it has a very rapid effect. So it peaks at 10 minutes and wanes after 1 hour. There's the suggestion that it might have some intrinsic anti-inflammatory effect and immunomodulatory effect, which might decrease the permeability of the injured blood-brain barrier. It also decreases the plasma viscosity, which might improve blood flow. And the hypertonicity of the hypertonic saline has direct relaxant effects on the vascular smooth muscle. It's also thought to be as effective as mannitol, and it's easy to monitor with sodium levels and might transiently actually increase the cardiac output, which might also be helpful. In terms of disadvantages for mannitol, there's a lot of adverse effects. So it can cause hypotension, mainly from the diuresis. It can actually also cause hyponatremia through this. It can cause polyuria because of that massive diuresis from the osmotic effect. And this can be confounding in the setting of a traumatic brain injury, as you can imagine that like If someone has severe traumatic brain injury and then goes into DI, that can be another differential for polyuria, so it can confound that. It can precipitate short-term volume overload in susceptible patients because it has that initial volume expansion effect. And then from a logistic point of view, it's unstable in storage and at low temperatures and at high altitude. It's hard to monitor because to monitor you need a serum osmolality, which can take time and might not actually be available, especially in certain regional centres. And it is a medium for bacterial and fungal growth. Compared to hypertonic saline, the adverse effects of that are hypokalemia, hyperchloremic acidosis, and there is a possibility of seizures or central pontine myelinolysis if given to a patient who is chronically hyponatremic. But this actually in practice, when given for osmotherapy effect, doesn't really seem to bear out when we look at studies or even observational anecdotal cases. It can cause phlebitis because it is irritative because of hypertonicity. And it has been shown to decrease platelet aggregation, increase clotting time, which is a worry for patients with traumatic brain injuries because you worry about secondary increase in hemorrhage. But this in studies have only been found to occur with large volumes. So if they're about 7.5 to 10% of total blood volume is replaced with the hypertonic saline, which realistically you're very unlikely to do when you're using this as an osmotherapy for raised intracranial pressure. From a logistic point of view, ideally you need central access if you're given longer term use, but like if you're giving it for raised ICP, we give it peripherally. There's no standards for concentration. So you'll see in different studies or even in different centres, some people use 3%, some people use 10% or 7.5%. So it can be hard to then compare, or if you're giving advice over the phone and you're used to one concentration and you ask for a certain dose, you might be giving the wrong dose if they have a different concentration available at their centre. It can cause acute heart failure or pulmonary edema if there's precipitated an acute hyperosmolar state. It has, like I said, maybe altered platelet aggregation, may affect the normal brain more than the injured brain. And there's a lack of outcome data for it because it's newer compared to mannitol. I think, though, at the end of the day, use what your centre has available and what you're more comfortable with. But I think that it seems to be a trend to be using hypertonic saline more than mannitol these days.
Yeah, and I tend to agree because of a lot of side effects associated with mannitol. And also one of the things that everybody needs to be mindful that mannitol cannot be given as an infusion. It has to be given as a bolus because it works only in that form. Onset time, as you mentioned, is 15 to 30 minutes. But if you start giving continuous infusion because you think that this will help us to keep the intracranial pressure on the lower side, actually the prolonged administration of mannitol moves the fluid into cerebral interstitial space and actually may exacerbate cerebral edema and raise intracranial pressure. So it can be quite tricky to deal with mannitol. And there are a lot of contraindication, and especially if patient is not making any urine or has got a renal injury, again, best to avoid mannitol. Yeah, hypertonic saline is the way to go. And I hope most of the even regional centers will have access to hypertonic saline. But again, in one of the things that you think about is do best what you can in that particular situation. One other interesting contraindication for mannitol is often talked about is the presence of epidural hematoma. Because if you give mannitol in this setting, because the blood is outside the dura and giving the mannitol, likelihood that brain will shrink, the epidural hematoma will expand. And I think that has potential to worsen the situation than helping the situation. And that's why one of the suggestion always is going to be don't give it unless you have a CT scan evidence of or you're ruled out the epidural hematoma. So let's move on to this patient scenario now. So you gave osmotherapy in terms of hypertonic saline, and then pupils have become reactive, and now the patient is urgently transferred to your hospital, and then the CT scan demonstrated acute subdural hematoma for which he required decompressive craniectomy. Can you please outline the rationale and evidence for decompressive craniectomy post-traumatic brain injury?
So the rationale basically surrounds the idea that intracranial hypertension after these injuries contributes to a secondary brain injury, which results in increased morbidity and mortality post-TBIs. And we know that the Monro-Kelly doctrine describes the pressure-volume relationship between the intracranial contents and the intracranial pressure. And it states that the skull is a rigid structure with a fixed space within it. So any increase in volume of its contents, be that brain, CSF or blood, must be compensated for by a decrease in volume of the other component, or there'll be a rise in the intracranial pressure. So therefore, the decompressive craniectomy increases the volume available to the intracranial contents by taking off the that fixed space. Or people might say like it's like taking off the lid of a rigid box, so allowing the contents to swell up. The main evidence for decompressive craniectomy or surrounding decompressive craniectomy post TBI, two major studies, one called DECRA, which was done in 2011, and one called Rescue ICP. So DECRA was an international multi-center RCT of 155 patients with a severe TBI, and refractory raised ICP, which was defined as an ICP of greater than 20 for 15 minutes. Which was either continuous or intermittent within 1 hour, despite optimized tier 1 interventions. And they were randomized to either decompressive craniectomy and standard care or to standard care alone, and the primary outcome being the median GOS-E at 6 months. And they found that there was a worse outcome in the decompressive craniectomy group, where the GOS-E score was 3 in this group versus 4 in standard care. In terms of secondary outcomes, so they also looked at proportion of unfavorable outcomes so that was a GOS-E of 1 to 4 at 6 months, that was worse in the decompressive craniectomy group. There was no difference in mortality, and unsurprisingly, there was a decreased ICP in the surgical group, and also decreased mechanical ventilation and days in ICU in the surgical. This study has been criticised mainly surrounding the external validity. So a lot of the critique is about there having a lower than, I guess, what would be standard practice ICP threshold for eligibility for a decompressive craniectomy. And the other thing was that the surgical technique was mandated as a bilateral craniectomy, which isn't the standard in many institutions. Also, the decompressive craniectomy group had a large proportion of patients with unreacted pupils, which potentially reflects more severe injuries. And there was a crossover rate of 18% from the medical to the surgical arm. In the second study, is a little bit more recent, was Rescue ICP, which was also an international multi-center RCT of more patients. So it was 408 patients with a traumatic brain injury, abnormal CT brain, and ICP monitor in situ, and they had a higher ICP threshold, so an ICP of greater than 25 millimeters of mercury for 1 to 12 hours, despite tier 1 or tier 2 measures to reduce the ICP. But barbiturates weren't allowed as part of that. They were randomized to decompressive craniectomy or continuation of tier 1 and tier 2 treatments plus barbiturates. And the primary outcome was, again, the GOS-E at 6 months. So they found that there was a lower mortality in the craniectomy group, but a higher rate of vegetative states, lower severe disability and upper severe disability, but similar rates of moderate disability and good recovery. And in terms of the secondary outcomes, it was a GOS-E at 12 months, and the craniectomy group had a higher rate of favourable outcomes with a GOS-E at 12 months. But the critique again of this, once again, it wasn't blinded, but it's kind of unfeasible because it's pretty obvious if a patient has a decompressive craniectomy. There was a high crossover rate again, 37% from the medical group to having craniectomy. And the conventionally used favourable outcome for most studies, if they're using a GOS-E, is score of 5 to 8, whereas this used favourable outcome as 4 to 8. And if the conventionally used favourable outcome of 5 to 8 is used, then there was actually no difference between the two groups. So even though they said that there was a difference between the sort of the primary outcome, it was mainly surrounding the definition of what they had or the threshold that they had for GOS-E. So that's always tricky. So I think on the whole, what we generally think about from the evidence from decompressive craniectomy is that it might give us more survivors, but they might be having worse morbidity. That being said, we don't know for an individual patient what this means, because it is like traumatic brain injury can be quite a heterogeneous kind of population, and some people might benefit more from having a decompressive craniectomy than others, and which patients that is hard to elucidate.
Yeah, absolutely. And that's why always the decision is done on a case by case basis. And usually the tendency or the current trend, at least in Australia and New Zealand, is for younger patients with severe TBI, we tend to perform decompressive cranectomies in general more than elder patients who are more than age of 80 or 75. Now, there's another interesting trial which was published in New England Journal of Medicine, which is very relevant to this topic, called as Rescue ASDH trial, which was published in 2023. And we did cover this trial on our eCrit Care podcast. It's quite interesting because in this trial, they compared the craniotomy approach versus decompressive craniotomy approach for acute subdural hematoma. And they studied 450 patients and randomized into two groups. And then they tried to find out which approach is actually better, because most of the time for subdural hematoma, you should be just performing the craniotomy. But what they found, there was no difference in overall long-term outcome with GOSE. And they were obviously, as you said, the survivors are there, but the overall outcomes with regards to morbidity were not different between the two approaches. Having said that, patients who underwent craniotomy approach required additional surgeries within the 2 weeks' time. On the contrary, patients who underwent craniotomy surgery, they had a higher incidence of wound infection complications, which is quite significantly higher. So it really, again, depends on the surgeon preference, the severity of the hematoma, and what the CTs can look like, and what's the kind of estimated pressures at that time of the surgery. Because sometimes the argument is you just do decompressive craniotomy, and why to put patient through another surgery within 2 to 3 weeks time. But also just be mindful that decompressive craniotomy also comes with a higher risk of infections compared to craniotomy. So it's quite interesting trial. Definitely have a read of it, and make sure that you are aware of this trial.
I think the other thing is have some familiarity about the GOSE score, because it seems to be like the outcome measure that a lot of the trials are using that to do with sort of traumatic brain injuries or neurointensive care studies.
Absolutely. And I think most of the trials are now powered with using the GOSE score rather than using the mortality, because with the mortality, doing these trials as a primary endpoint is quite hard, because then you need a large sample size. And also, I think GOSE is probably the most meaningful outcome in this cohort of patients, because that's what we really want to know after 1 year, how these patients perform in their day-to-day life if they survive. So, Maddie, that's the end of our today's snippet. We'll be back with another snippet soon. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.